عليك وعبالي وصحبي وصلاتي وصلاتي. بداية أوجه خالص الشكر إلى شقيقي الأستاذ الدكتور حسام طه والأستاذ الدكتور حسين على أن أتاح لي هذه الفرصة لأقف أمام هذا الحشد وهذه مجموعة من الأطفال من أطباء الأطفال وأطباء جراحة الصدر وأطباء البطن أيضا، فلهم الشكر على إتاحة هذه الفرصة. الحقيقة لو أعرف إن هيبقى معانا عدد كبير قوي من بتوع جراحة الصدر كنت قلبتهم، أنا ممكن أقلبه على فكرة بس من غير برزنتيشن. كنا بنتكلم على حاجة ريسبيراتوري ديسوردرز، أنا أم ريدي بس المشكلة بس في البرزنتيشن أنا ممكن نتكلم من غير سلايدز عادي. خلينا في النيونيتال سيجرز اللي احنا بنعرفها. I will talk today about neonatal seizures. Simply, this is an overview of what we are going to talk about. We start with the definition of neonatal seizures. Seizures represent the most distinct signal of neurological disease in the newborn period. A seizure is defined as any paroxysmal alteration in neurologic function, whether this alteration is behavioral, motor, or autonomic, even if it applies to changes that occur in the EEG without apparent clinical manifestations. Thus, a seizure is any paroxysmal alteration in neurologic function. For how long of time we say that these are neonatal seizures? Neonatal seizures occur during the first 28 days of life in term infants and occur within 44 weeks of gestation in preterm infants. If a preterm infant is delivered at 30 weeks gestation, if he develops seizures during the next 14 weeks after labor, they are considered as neonatal seizures. But for the full-term baby, neonatal seizures are confined to the first 28 days of life. But in the preterm, they include the first 44, any seizure which occurs within 44 weeks of gestation. The incidence of neonatal seizures in term versus preterm infants. In term infants, the incidence is approximately 1.5 to 3 per 1,000 big person. In preterm infants, the incidence is higher, approximately 50 to 150 per 1,000 big preterm person. Incidence as a function of birth weight. Neonatal seizures occur or represent the incidence of neonatal seizures is approximately 57.5 per 1,000 in infants weighing less than 1,500 grams and 2.8 per 1,000 in infants weighing 250 to 39 grams. البيرث ويت مهم قوي والجستيشنال ايج مهم قوي في الانسيدنس of neonatal seizures. Precise frequency is difficult to eliminate. Most of neonatal seizures we know is based on clinical observation. EEG monitoring with video recorder or direct inspection show that some clinical seizures do not have EEG correlation. Some electrographic seizures are not accompanied by clinical seizures. In many situations, there is dissociation between the clinical observation and the EEG findings. Clinical impact of history on etiology of seizures. Clinical history provides important clue to the etiology of neonatal seizures. Family history may suggest genetic syndrome. Many of these syndromes are benign. In the absence of other etiologies, family history of seizures may suggest good prognosis. Pregnancy history is important. Search for history that supports torch infections, history of fetal distress, preeclampsia or maternal infections. Delivery history, type of delivery and antecedent events. Apgar scores offer some guidance. Low Apgar score without the need for resuscitation and subsequent neonatal intensive care is unlikely to be associated with neonatal seizures. Postnatal history. Neonatal seizures in infants without uneventful antenatal history and delivery may result from postnatal cause. Tremulousness may be secondary to drug withdrawal or hypocalcemia. Temperature and blood pressure instability may suggest infection. What are the causes of neonatal seizures? This table summarizes the cause of neonatal seizures according to frequency. The most common cause of neonatal seizures is hypoxic ischemic encephalopathy, accounting for approximately 30 to 53% of all neonatal seizures. The second most frequent cause is intracranial hemorrhage, representing 7 to 17%, then cerebral infarction, an item that we usually neglect in our practice. Cerebral infarction represents approximately 6 to 17%, cerebral malformations do represent 3 to 17%, meningitis septicemia 2 to 12%, metabolic causes, hypoglycemia, hypocalcemia. Hypocalcemia is more frequent in practice than hypoglycemia. We have then other metabolic causes. We have maternal drug withdrawal, representing 4% of cases, idiopathic convulsions 2%, benign idiopathic neonatal seizures, and other seizures which don't have percentage, such as neonatal epileptic syndromes, congenital infections, unintentional injection of local anesthetics during labor, and maternal vitamin D deficiency. This is a summary of etiology of neonatal seizures. Then etiologies in relation to time of onset and relative frequency of neonatal seizures. Hypoxic ischemic encephalopathy, seizures due to hypoxic ischemic encephalopathy usually present during the first 3 days of life, not beyond the third day, and they equally occur in premature and full-term infants. Intracranial hemorrhage can occur at any time. Seizures due to intracranial hemorrhage, can occur at any time, and they are more frequent in premature and full-term infants. Intracranial infections, seizures due to them, can occur at any time and can equally occur in preterm and full-term infants. Developmental effects also. Hypoglycemia, seizures due to neonatal hypoglycemia are usually present on the first 3 days of life, and they occur equally in preterm and full-term. Hypocalcemia can occur at any time. Other metabolic disturbances occur also early, but they are more frequent in full-term infants. Epileptic syndromes more common in full-term than preterm infants and can occur at any time during the neonatal period. The question now is, why is the neonatal brain prone to seizures? Seizures result. When will seizures occur? Seizures will occur when there is excessive synchronization of clinical discharge or depolarization of neurons within central nervous system. The seizure is a clinical reflection of excessive depolarization within the neurons of the central nervous system. What does the term depolarization mean? Depolarization means inward migration of sodium. It's well known that sodium is the main extracellular cation. This is the outside of the cell, and this is the inside of the cell. Sodium is the main extracellular cation, potassium is the main intracellular cation. If excess sodium is allowed to migrate to the inside of the cell, this means depolarization. Excessive depolarization will result in seizures. Polarization means inward migration of sodium. Maintenance of membrane energy. What maintains sodium outside and potassium inside? This is the function of the energy production by the cell, which is mediated by adenosine triphosphate. Thus, maintenance of membrane potential requires energy. This energy, represented in ATP, extrudes sodium out and takes potassium in. Seizure results. Relative excess of excitatory versus inhibitory neurotransmitter result in excessive depolarization. The main excitatory neurotransmitter in the cerebral cortex or in the brain in general is glutamate. Hypoxia, ischemia, and hypoglycemia will result in excessive release of glutamate and diminished reuptake by energy-dependent transport in presynaptic nerve endings and glia. This will result in increased concentration of glutamate. This will result in increased concentration of glutamate. Relative deficiency of inhibitory versus excitatory neurotransmitter result in excessive depolarization. GABA is the main inhibitory neurotransmitter. Pyridoxine dependency. Pyridoxine is a critical factor of glutamic acid decarboxylase. This is the synthetic enzyme of GABA, thus resulting in disturbance in binding, which will result in decreased GABA production, inhibitory synapses were blocked and not well developed. Calcium and magnesium. We have two factors now. Hypoxia, ischemia, and hypoglycemia will result in decreased energy production, and they will result in also increased excitatory transmitters. Pyridoxine deficiency will result in decreased inhibitory neurotransmitter. We have then calcium and magnesium. Calcium and magnesium interact with the neuronal membrane to cause inhibition of sodium movement. Thus, hypocalcemia and hypomagnesemia will result in increased sodium influx and excessive depolarization. Now, what are the probable mechanisms of neonatal seizures? We have four mechanisms for neonatal seizures. The first mechanism is failure of sodium-potassium pump secondary to decreased adenosine triphosphate. This is encountered in hypoglycemia, ischemia, and hypoxemia, ischemia, and hypoglycemia. The second mechanism is excess of excitatory neurotransmitter. This is encountered also in hypoxemia, ischemia, and hypoglycemia. The third mechanism is deficit of inhibitory neurotransmitter encountered with pyridoxine dependency. And the fourth mechanism is membrane alteration, increased sodium permeability associated with hypocalcemia and hypomagnesemia. Those are the four probable mechanisms of neonatal seizures. The next question, why do seizures manifest differently in neonates? The presentation of neonatal seizures is different from the presentation of seizures in older children or adults. Why? Seizures in newborns differ from those seen in older children and adults. Seizures in preterm infants even differ from term infants. Newborns rarely have well-organized, generalized tonic-clonic seizures. شوفهاش خالص في النيوبورن. Well-organized, generalized tonic-clonic seizures are not seen in newborns. Preterm infants have even less well-organized spells than term infants. Seizures in newborns differ from those seen. Immature brain seems more prone to seizures than the more mature brain. Differences relate to the status of neuroanatomical and neurophysiological development in the perinatal period. The difference in seizures in neonates from older children and adults, and even the difference in the seizure pattern in preterms than full-term infants relates to neuroanatomical and neurophysiological developments in the neonatal or in the perinatal period. What are these differences? We come now to the perinatal anatomical features. Neonatal growth, dendritic and axonal ramifications are still in process. They are still developing. Synaptogenesis is not complete. Deficient myelination in cortical efferent systems. This prevents conduction of epileptic discharges out of the brain in a generalized fashion. And this will result in weakly propagated, fragmentary, focal and short-lasting seizures which may not be apparent on EEG. Newborn monkey have more advanced cerebral cortical organization, myelination of cortical efferent systems, and interhemispheric formation. ودي حاجة غريبة سبحان الله إن النيوبورن monkey has a more developed cerebral cortex than the full-term human. حاجة من عند ربنا. This result is that newborn monkeys are likely to develop generalized seizures apparent clinically and electrographically. It's not present in the full-term human. Another anatomic factor in the perinatal, one of the other perinatal anatomical features is the limbic system. Limbic system with connections to midbrain and brainstem is more developed than the cerebral cortical organization. Subcortical areas are more developed in the neonatal period than the cerebral cortex. Limbic system with connections to midbrain and brainstem is more developed than the cerebral cortical organization. What does it mean? It means higher frequency of oral, buccal, lingual, clinical manifestations of neonatal seizures, sucking, chewing, drooling, oculomotor phenomena such as eye deviation and apnea. Neurophysiological features in limbic and neurocortical regions. Excitatory synapses develop before inhibitory synapses. مهم قوي. Excitatory synapses develop before inhibitory synapses. This means that the neonatal brain is more subject to excitation than being inhibited. In early development, GABA acts to produce excitation rather than inhibition. The main inhibitory neurotransmitter is GABA. In the early neonatal period of early development, GABA, which is the main inhibitory neurotransmitter, acts as an excitatory rather than inhibitory. Immature hippocampal and cortical neurons are more susceptible to seizure activity than mature neurons. Other neurophysiological features: deficient development of substantia nigra system for inhibition. Only the pro-convulsant projection network functions in early brain development. Impaired propagation of electrical seizures and synchronous discharges recorded from surface EEG might not correlate with behavioral seizure phenomena due to deficient demyelination of the cerebral efferent systems. Now we come to the classification of neonatal seizures. We classify neonatal seizures into clinical seizures, EEG seizures with an epileptic or non-epileptic. What is epileptic and non-epileptic seizures? An epileptic seizure is generated by hypersynchronous discharges that might spread and activate other brain structures. Cannot be provoked by tactile stimulation. Cannot be suppressed by restraint of involved limb or repositioning of infant. Consistently associated with electrocortical seizure activity or EEG. These are the features of the epileptic seizure. The non-epileptic seizure, paroxysmal clinical phenomena that are not consistently associated with EEG seizure activity, provoked by stimulation, suppressed by restraint and repositioning of infant. Now we come to the types of neonatal seizures, clinical seizures. We have subtle seizures, clonic with a focal or multifocal, tonic with a focal or generalized, myoclonic with a focal, multifocal or generalized. Subtle seizures are EEG correlation are present with subtle seizures, with chronic seizures with a focal or multifocal, with focal tonic but not with focal clonic seizures, with myoclonic but with generalized myoclonic but not with multifocal or focal myoclonic seizures. Now we come to subtle seizures. Selected major manifestations include ocular phenomena, tonic horizontal deviation of eyes with or without jerking of eyes, sustained eye opening with ocular fixation, oral buccal lingual movements such as chewing, sucking, lip smacking, lip movements such as cycling, swimming, and rowing, autonomic phenomena, increased blood pressure, brady or tachycardia, and apneic spirits. بركز عليها حته الايكونوميك فينومينا ديت في النيوتال براكتس. يعني ماني تايمز العيل ماشي معانا كويس قوي مره واحده يتاخد في برادي كارديو ملاش اكسبلانيشن خالص. بعدين يرجع عضو تاني. بعد شويه يخش في تاكي كارديو ويرجع عضو تاني. نحط دايما البوسيبيليتي اوف اوتونوميك سيجرز very common presentation of neonatal seizures. Chronic seizures usually involve one limb or one side of the body jerking rhythmically at 1 to 4 times per second. عشان نفرقها وبينها وبين الجيترنس. And chronic seizures usually involve one limb or one side of the body jerking rhythmically at 1 to 4 times per second. Focal clonic seizures will localize clonic jerking. Infant usually not unconscious. يعني العيل بيبقى usually ايه؟ conscious. Multifocal clonic seizures involve several parts of the body in migrating fashion. Non-ordered fashion، ما لهاش ترتيبة بس هي migrating. Simultaneous or in sequence. تيجي مع بعضها tonic focal tonic seizures sustain posturing of limb. Asymmetrical posturing of trunk and neck. Generalized tonic seizures, tonic extension of upper and lower extremities, tonic extension of upper and lower extremities, tonic flexion of upper limbs, and extension of lower limbs. زي ما احنا شايفين في flexion في upper وفي extension في lower limbs. Most are not accompanied by EEG seizure discharge. Only 30% have EEG correlates. Myoclonic seizures, focal and multifocal myoclonic seizures will localize single, multiple, migrating jerks, usually of limbs. الكرونيك اللي فيها الميستي 1 to 4 per second. هنا ما فيش الميستي. will localize single, multiple, migrating jerks, usually of limbs. زي ما يكون العيل ايه؟ ياخد تقطيعه كده بيفرد نفسه كده شويه. Usually not accompanied by EEG seizure discharge. Focal typically involves flexor muscles of the upper extremity. The multifocal asynchronous twitching of several parts of the body. Myoclonic seizures is generalized myoclonic seizures, single or several bilateral synchronous jerks of flexion occur more upper than lower limbs, may predict infantile spasm with suppression burst electroencephalogram and typical epsilon. طيب what normal ده السؤال بقى مهم قوي. What normal neonatal activity is mistaken for seizures؟ كتير قوي بنشوفها. يا ترى العيل ده seizure activity ولا normal activity mimicking a seizure؟ ايه الحاجات اللي ممكن تبقى بقى؟ awake or drowsy. العيل صاحي او بيصبي كده ممكن يحصل ايه بقى؟ moving sometimes spongible eye movement. تلاقي العيل عينيه بعدت عن بعضها شويه وقربت من بعضها شويه. تمام؟ دي normal activity. Sucking or puckering movements not associated with ocular fixation or deviation. مهم قوي. ساعات يقول لك العيل انت بتبص على العيل وانت بتشوفه عمال يمصمص في شفايفه كده. يا ترى دي صفة سيجر ولا لا؟ بص على الايز. لو لقينا فيه deviation of the eyes يبقى دي seizure activity. لو ما كانش معاها deviation of the eyes يبقى دي normal activity ما فيهاش مشاكل. Sleep. Fragmentary myoclonic jerks might be multiple. العيل وهو نايم يقعد يقطع كام تقطيعه كده وممكن تبقى multiple بس هو ستيبل. السيجر activity بتحصل وهو awake. المايوكلونيك seizures بتحصل وهو awake. Isolated generalized myoclonic jerk as an infant wakes from sleep. العيل اول ما يصحى من النوم يعمل شويه حركات بسيطه في ظهره كده قريبه قوي من المايوكلونيك جيركس. يبقى دي normal activity which mimics seizure activity. Now we come to like to differentiate between gentleness and seizure. في gentleness abnormality of gaze or eye movement مش موجوده not present but present in seizure. Movements stimulus. هل الاكتيفيتي ديت او الموفمنت دي محتاجه ستيمولس ولا لا؟ present in gentleness not present in the seizure. The seizure is not precipitated by any stimulus. Predominant movement في الجنتلنس بتبقى tremors. في السيجرز كلونيك جيرك. ايه الفرق بين الاثنين؟ ان التريمورز الفريكونسي بتاعها عالي قوي، تلاقي العين بتاعه عماله ترعش كده 20 مره، ممكن يعمل 20 مره في الثانيه الواحده. انما في السيجر اكتيفيتي من 1 ل 4 في السكند بير سكند. Movement ceases with passive flexion. This occurs with gentleness but does not occur with seizure. Anatomic changes occur with seizure, but autonomic changes occur with seizure activity but don't occur with gentleness. العيل بتاع الجنتلنس ما يحصلوش بالور، ما يحصلوش دايليتيشن اوف ذا بيوبلز، ما يحصلوش هايبوتنشن، ما يحصلوش تاكيكارديا وبراديكارديا. كل ديت لو حصل تبقى اوتونوميك مانيفستيشنز ان فيفر اوف سيجر اكتيفيتي. Now we come to the workup for neonatal seizures. We have blood tests, complete blood count, differential, including platelet count, glucose, electrolytes, calcium, magnesium, arterial blood gases, lactate and amino acids that the whole of metabolism is suspected. CSF studies, cell count, glucose, protein, bacterial culture, herpes simplex, polymerase chain reaction and culture if HCV is suspected, urine analysis and toxicology screening. Congenital infections screening, serum titers in mother and child for TORCH, urine culture for cytomegalovirus, inborn errors of metabolism. اليورين كلتشر في cytomegalovirus احنا بنغفل عنها على فكره ومعظم العالم ما بتعملهاش وفيري رابيد تيست فور دايجنوز وفيري كونفيرمتيف تيست فور دايجنوز of recent cytomegalovirus infection. Inborn errors of metabolism screening, plasma amino acids and organic acids, urine organic acids, serum lactate and ammonia, electroencephalogram, head sonogram, CT scan, and brain MRI. Then we come to short comment on the EEG. Electroencephalogram essential in diagnosis and management of neonatal seizures, usually obtained during interictal period. Measure values of EEG. First, determine if an infant with subtle seizure is experiencing epileptic seizure or not. And the second, determine whether a paralyzed infant is experiencing convulsive phenomena. Third, define interictal backgrounds which are of value in estimating prognosis. Those are the main values of EEG in neonatal practice. Serial and continuous EEG video monitoring is more important than a single record of EEG. Why should infant with neonatal seizures be treated? And if I have a neonate with seizures, should this neonate be treated or not? It should be treated. Why? Usually related to significant illness requiring therapy. يعني الحاجة اللي هتعمل neonatal seizure is usually a significant illness that needs for therapy. Second, potential adverse effects of seizure on circulation and cerebral metabolism. Seizure per se will have its adverse effects on circulation and cerebral metabolism. And third, seizure will interfere with supportive measures. أنا عايز أعمل supportive measures العيل ده، عايز أعمل له assisted ventilation، عايز أعمل له alimentation، عايز أعمل له أي supportive measure. If he is in a seizure activity, I can't do these supportive measures. And then concern that repeated seizures cause brain injury. Whatever the cause of seizures, صرف النظر عن الجزء هو repeated seizures, whatever the etiology, seizures per se, if repeated, they are going to be associated with brain injury. These are the mechanisms of brain injury with repeated seizures. Repeated seizures will induce four important actions, will induce four important effects. The first effect is hypoventilation and apnea, and the second effect is increased blood pressure. The third effect is decreased adenosine triphosphate, and the fourth effect is release of excitatory amino acids. Hypoventilation and apnea will result in accumulation of carbon dioxide and decreased oxygen. Decreased PaO2 will result in cardiovascular collapse, decreased blood flow, including decreased cerebral, which can result in brain injury. Hypercapnia, together with increased lactate resulting from the elevated blood pressure and the decreased adenosine triphosphate and subsequent glycolysis, will result in increased cerebral blood flow, and this is likely to induce hemorrhage. This is likely to induce hemorrhage and brain injury. Decreased ATP will result in glycolysis, increased glycolysis, decreased brain glucose and brain injury. And lastly, release of excitatory amino acids will result in increased concentration of excitatory amino acids and brain injury. How do you treat neonatal seizures? If there is a specific cause for neonatal seizure, first of all, before treatment, we have to consider adequate ventilation and perfusion. احنا كلنا بنهتم بالسيجر، مهم قوي قوي الله يخليك السبورتيف كير الاول، adequate ventilation and perfusion. If with hypoglycemia, we give glucose. If with hypocalcemia, we give calcium, hypomagnesemia, magnesium sulfate, pyridoxine deficiency, and ندي pyridoxine, meningitis, ندي antibiotic therapy. The question now is, what about anti-epileptics in neonatal practice? Those are the most important anti-epileptic drugs used in neonatal practice: phenobarb, phenytoin, phosphonatoin, and lorazepam and diazepam. anti-orthosis موجودة طبعا لو حد حب ياخدها بعد المحاضرة. Expected response of neonatal seizures to sequence of therapy. With phenobarbital 20 mg per kg, cessation of seizures occurs in 40% of units with seizures. With phenobarb 40 mg per kg, seizures cease in approximately 70%. Phenytoin 20 mg per kg in 85, the response is 85%. Lorazepam 0.05 to 0.1 mg per kg, seizures cease in approximately 95 to 100%. So the drug choice to stop seizures is lorazepam. But the ideal drug to start with is phenobarbital. Other anti-epileptic drugs, we have intravenous anti-epileptic drugs such as high-dose phenobarb and so on, salbutamol. Oral anti-epileptic drugs. How long do we treat neonatal seizures؟ السؤال اللي بيحيرنا في neonatal practice. No consensus about the duration of anti-epileptics in neonatal practice. In neonatology, neonatologists discontinue anti-epileptic drugs earlier than pediatric neurologists. في النيوناتولوجي بمجرد ما سيجرز تقف ابتدي اعمل withdrawal of anti-epileptic drugs واوقف. بتوع البيدياتريك نيورولوجي بيحبوا فتره اطول. What are the determinants of treatment duration؟ عايزين نحط قواعد ثابته. What are the determinants of treatment duration؟ Three important determinants. The first is neonatal neurological examination, and the second is course of neonatal seizures, and the third is the EEG. Those are the three determinants of treatment duration. Anti-epileptic drugs have detrimental effects on the developing brain. نقطة مهمة لازم نحطها إن الأنتي-epileptic drugs بتأثر على cognitive functions. Stepwise approach بقى to discontinuation of anti-epileptic drugs. If neonatal neurological examination becomes normal, discontinue therapy. مفيش أي abnormality في neurological examination and discontinue therapy. If neonatal neurological examination is persistently abnormal, consider etiology and obtain EEG. In most cases, continue phenobarb, discontinue phenytoin, and re-evaluate in 1 month. Then, if the neurological examination is persistently abnormal, كل ما اجي اعمل examination الاقي فيه abnormality. يبقى في الوقت ده لازم احط في دماغي الايتيولوجي بتاع العيان ده واعمل EEG، هكمل الفينوبارب وهوقف الفينايتوين. على اعتبار ان الكونفرجنس خلاص seizure ceased. After 1 month, if neurological examination has become normal, discontinue phenobarb. If neurological examination is persistently abnormal, obtain another EEG. If no seizure activity on EEG ما طلعش أي seizure activity, discontinue phenobarb. رغم ان neurological examination is still abnormal. Other modes of therapy have surgical option. Neonatal seizures caused by cerebral malformations or developmental defects resistant to medical therapy. Surgery is usually performed later in infancy. What is the prognosis of neonatal seizures? Prognosis improved over the past decades. Mortality decreased from 40% to 20%. Incidence of neurological sequelae 25 to 50% according to the etiology. Mental retardation, cerebral palsy, spasticity, hydrocephalus, epilepsy in 17 to 56% of cases, feeding difficulties and microcephaly. In relation to neurological examination, normal neurological examination after cessation of neonatal seizures is usually associated with good prognosis. Abnormal neurological examination is usually predictive of poor prognosis. Early predictors of poor prognosis in neonatal seizures. 5-minute Apgar score less than 7, need for resuscitation after 5 minutes of age, seizures lasting more than 30 minutes. All predictors of poor outcome in neonatal seizures. In relation to EEG, if EEG background is normal, the prognosis is excellent for seizures to resolve. Normal development is likely. Severe EEG background abnormalities indicate poor prognosis. Such patients frequently have cerebral epilepsy. The presence of spikes in EEG is associated with a 30% risk of developing future epilepsy. Prognosis of seizures according to etiology. Hypoxic ischemic encephalopathy, normal development occurs 50% according to the grade of encephalopathy. Intraventricular hemorrhage, 10% abnormal development. Primary subarachnoid hemorrhage 90%. ودي الحاجه الغريبه ان احنا شفنا حالات كتير قوي massive subarachnoid hemorrhage and develop normally after that. Hypocalcemia, early onset hypocalcemia, normal development to 50% and 50% will develop abnormalities. Late onset hypocalcemia is associated with 100% normal development. Bacterial meningitis 50%, hypoglycemia 50%, developmental defects, there is no normal development in newborns with developmental defects. Future or further patient care, follow-up is important, neonatal evaluation, early identification of physical and cognitive deficits, anti-epileptic drug level monitoring, treatment assessment, consultation and follow-up with pediatric neurologist, parent and family education. الحقيقة دي كانت محاضرة ثانية شبكة المحاضرة الأولانية، فأعتقد كده كفاية أوي. أشكركم على الاستماع وأرجو أن ما أكونش ضايقتكم.